I'm presenting a poster focusing on the response of PV patients who were not randomized on ruxolitinib as when they entered the trial, that were randomized on the best available therapy arm, and then who crossed over to ruxolitinib after the end of the trial or because they progressed on BAT. So the aim of this poster is to show that in this additional cohort of patients who were refractory to hydroxyurea or resistant to hydroxyurea or intolerant, that received ruxolitinib after the end of the primary endpoint of the trial. In fact, they responded as well as the patients who received ruxolitinib frontline when they entered in the trial. There was almost the same response rates in terms of control of hematocrit, the same response rate in terms of control of leukocytosis, thrombocytosis, but a bit less, a response which was a bit less for the splenomegaly than the patients who received it directly as a first-line therapy. However, it further confirmed that this drug is efficient to control the hematocrit and blood count in PV patients after they have been resistant to hydroxyurea, for example. We didn't have really a second-line drug approved in PV patients, or a second drug, even not for second line. In Europe, especially in France and Italy, we have another alkylating agent named pypobromine that is approved for PV, but we have shown in the French group that this drug was quite leucemogenic on the long term, especially when it was added after ruxolitinib, after hydroxyurea, sorry. So there's a real need for PV patients who do not tolerate hydroxyurea for another drug that is not leucemogenic and that may provide, help them to solve the thrombotic problems or hemorrhage problems. In addition, I would say that ruxolitinib has been very efficient to treat some symptoms that are sometimes a huge problem for patients, including pruritus. Pruritus is a frequent symptom in PV, but sometimes in few patients it's really a main problem with a itching that is terrible and resistant to any drug. And there, this JAK1, JAK2 inhibitor, ruxolitinib, is very, very efficient to treat that. So we have the control of the hematopoiesis, let's say, and also a clear improvement in symptom and quality of life. So for those patients who do not tolerate hydroxyurea or to resist to this drug, it will be a clear improvement.